Good morning, everyone. It's Phil Pugh. We're going to go ahead and start it here in a minute. We'll give folks about 30 more seconds to join, and then we'll get started. As a reminder, this meeting is being recorded to be uploaded to our YouTube page later today. If you don't want to be recorded, feel free to log off now, and we will, again, upload to YouTube, and you can watch later. Thank you. All right, good morning, everyone. We'll go ahead and get started for our coalition meeting. This is the agenda. A few things just want to point out on this agenda today is that the monthly topics that we have listed there as being D4H and EMResource at the bottom. As we discussed a couple months ago, last 2 months, that we were transitioning to our new battle rhythm with themed monthly events, and those two are the themes. So with the traditional agenda attached, I'll just ask everyone if they can be as concise and as brief as possible so we can have some room on the end to have folks be able to remain online to go through a little bit of education and thoughts, questions, Q&As, etc. today. So here's our agenda today. So we'll go ahead and get started with our roll call, starting with our hospitals. We'll start with Anderson Hospital.
Hi, Phil. Eric's here representing Anderson and Community Hospital Staunton.
Thanks, Eric. Good morning. Alt Memorial.
Good morning, Phil. This is Aaron Alton.
Gotcha, Aaron. Thank you very much. Boyd.
Nancy William-Weber here.
Morning, Nancy. Carlinville Area Hospital.
Tyler's here for Carlinville.
Thanks, Tyler. Fayette. I see Tina. I know she'll hit the mute button here in a second.
Phil.
Good morning. All right. Gateway. Oh, Danielle has moved on. Rick, are you on by chance? And if not, is Kenny on? No one from Gateway this morning? Okay, maybe they'll join a little bit later. To our HS partners, we'll start with Holy Family. How about HSHS St. E's? How about Breeze? Last but not least, Highland.
Good morning, Patrick here from Highland.
Gotcha, Patrick. All right, we'll move on. Jersey Community Hospital. Anyone from Jersey Community? Nope. Belleville, you got myself, Lee French, Scott Klosterman. We're covering both Belleville and Shiloh. Mike Gilbert will be joining in a minute. I know he has someone in a meeting right now, but he should be joining. Memorial Hospital Chester.
This is Georgia. I'm here.
Good morning, Georgia. How about our good folks up at St. A's OSF?
Gary's here.
Gotcha, Gary. Thank you. Redbud.
This is Tara. I'm here.
Good morning, Tara. Sparta.
Dan and Dale are both on this morning. Phil.
D&D Factory. Dan and Dale. Gotcha. Thank you.
And Paula Cunningham, the ER manager from Sparta.
Oh, awesome. Awesome, Paula. Thank you very much. And Touche. Once, twice, thrice. Okay. Over to our health departments. We'll go Bond County.
Bond County here. This
Who
is
that,
Wendy.
Wendy? Gotcha.
This is
Perfect.
Wendy.
Calhoun? Calhoun, thank you, Wendy. About Clinton County?
Yeah, good morning. This is Brett at Clinton.
Gotcha, Brett. Thank you very much. Eastside Health District? Fayette County?
Kendra's here.
Thank you, Kendra. Greene County?
Molly's here.
Gotcha, Molly. And Jersey County?
Heidi's here.
Morning, Heidi. Macoupin County?
Derek here, Phil.
Gotcha, Derek. Thank you. Madison County?
Jacob's here.
Gotcha, Jacob. Thank you. Monroe County?
Here.
Gotcha, Vicky. Thank you. Randolph County?
Deborah's here.
Gotcha, Deborah. And St. Clair?
Good morning, this is Kara. I'm here.
Thank you, Kara. Our community partners in IDPH will start with our regional EMS coordinator. Greg, are you on?
I'm on, Phil.
Thank you, sir. Good morning. Our emergency response coordinator, Beth, are you on?
Hello, I'm here. Beth is here.
Gotcha. Thank you very much. Any of our BC partners? All right, any of our emergency management agency partners from the counties?
Good morning, Phil. It's Sam from EMA.
Gotcha, Sam. For St. Clair, thank you. Anyone else from the EMAs? Okay, hearing none. MedStar Ambulance?
Leanne's on.
Good morning. Good morning,
Good morning.
Phil. John's on.
Awesome. Got Leanne and John. Thank you. I figure you guys will be recouping after the weekend still. Lots of work, I know. Any of our folks from Abbott? Hearing none. How about SLU? Scott Air Force Base? What about STARS?
Morning, Phil. This is Nick. I am representing the coalition, and I don't believe there's any actual STARS members on this morning, so I can speak to a couple things from them.
Okay, so we'll pause for you if no one else joins. I appreciate that, Nick. And you're representing for the St. Louis Regional Healthcare Coalition as well. I can't tell if Jason is on. If he's on, you can shout it out anytime. Just checking the chat. I do see my good friend Michelle Tanton from Children's. Thank you for joining. Cindy, Holy Family, I see you on there. And Carla from Monroe County EMS. Thank you very much. If your name wasn't called, you want to make sure you get counted attended. Just drop a note in the chat. If you are calling via phone, you shoot us an email or what have you saying that you were present. I got you, Marty Hagan from Region 5. Appreciate it. All right, we'll start out just with a few of our due outs from the previous meeting. We'll try to get those covered now. We did have 2 outstanding items. I just don't know the status of those. The first was for all coalition members, and we'll cover that today to finalize their review of any of the plans and submit them via the comment review matrix. We will cover that in depth again today. And then one for Greg and John was checking with Dan Lee on those EM track issues. Did we get that resolved, Greg?
Well, I didn't hear back from John. John, I sent you an email. I'm trying to remember since it was a month ago. I thought your question was answered. Remind me. I'll have to look up in my.
Yeah.
John.
Yeah. I was trying to get unmuted. It's working out. What it was is I lost visibility of IDPH members So now all I have to do is click on IDPH and it just gives whoever would like to get on it and follow along the capability. So it just took away the individual members that were assigned or that I had in the drop down.
That was
Unders-
it. Yeah.
Understood.
Thanks, John.
John, you want to consider this one closed?
Yes, sir. I would say you could close that.
Okay, perfect. Thank you very much, sir. Appreciate it. All right, we'll start with Greg. IDPH, what you got for us, Greg?
I don't have much other than a reminder that the letters of commitment / participation, the deadline for that was extended to the end of this month for EMS providers. And then, of course, the participating associate and resource hospitals also need to complete those. So there will not be another extension according to Bobby, and there will need to be a plan of correction if we don't get those by the end of the month. But I'm starting to receive a bunch of them through the system coordinators, so I will try to get all of those checked off on the list, and hopefully shortly before the end of the month get word out to any entity that did not complete, so that they have like a week to get that done. The other thing is Dan did send out the monthly report, so I hope you all looked at it. I noticed there were a couple of hospitals who showed a marked improvement, so thank you to those. If any of you guys had part of that. A few of our hospitals do really good all the time, and then we still have some strugglers. So did you say you were going to talk on that, or were you going to have somebody on, Phil?
Yeah, we'll have some time dedicated for EMResource after after we're done with everything. We do have some time for that today.
Okay, and that's all I have, unless anybody has any questions.
Any questions for Greg? Okay, hearing none. Oh, hold on. I think we do have one. Tina, go ahead.
Greg, the letters that you're referring to, is it just the EMS systems or is it the hospitals?
No, the hospitals are part of the EMS system, so they also complete one. So you guys are, help me out, you're now a participating hospital with Anderson, isn't that right? Yes, you are. So you would complete, Fayette County Hospital would complete the participating hospital form and the material requested, and that would be sent to Anderson Hospital, who is your resource hospital, and they are collecting all of those from all their providers and hospitals and then sending them on to me.
So is there an email that goes through? Did it go through like the CEO because we've had a change, or where does that information come from?
I'd have to check with Darren, unless Darren's on this call and can say who he sent out that letter to, because all of the letters were sent directly to the EMS system coordinators to send to all of their hospitals and all of their ambulance providers, EMD agencies, etc. We can check. We can check with Darren's team.
Greg, I'll save you a phone call. Those haven't been sent out yet. We were waiting for you to return your response from the policies we submitted, but I guess we won't wait for that anymore. I didn't have any idea that I directed Darren to do so. I had no idea that there was a deadline attached to it, and then it has been extended. I never saw a deadline of the end of September. So I'm happy to see that the new deadline is in October. As for Tina, you'll get those today.
Yeah, okay, and I apologize. The letters of commitment don't have anything to do with the policies. So the policies
I'm aware.
submitted.
I'm aware of
Oh,
that,
okay,
but
okay.
yeah, I was
I
just
thought-
trying to finish one task before going on to the next one, and in my mind that worked better, but apparently it wasn't a good
Gotcha.
idea. So yeah.
Okay,
Perfect. Okay. Thank you, Greg. I will pause just for a quick second and hijack a little bit of IDPH time because I don't have a dedicated slide about the grant today, so I want to talk about it just briefly. But following our meeting on the 6th last month, on the 7th, apparently our grant was approved through IDPH. So I want to give a big shout out and a thanks to the folks at IDPH and everyone else who submitted project requests and all those things to get things submitted on time. Our grants management office, everyone for processing everything. So this would be the fastest, literally the fastest. That's like, let me see, July, August. So 60 days or 66 days into or 67 days into the new grant year, our grant is approved. For those who've been around here for a while, that normally doesn't happen until at the earliest, maybe February, March of next year. So some of you have already, those who did submit project requests have been working or received some information from our grants management office and completing some of the required paperwork for the grant. So hopefully you guys will get that information back as quickly as possible, your risk assessments and all the assorted documents that the grants management office requires, so we can get to spending money in a timely fashion this year. So this will be again, much needed for us here and will only make things better going forward. So much appreciated, and we will continue to grow. Any questions just generally about the grant from anyone?
Yeah, this is Molly in Green.
Yes, ma'am.
And I just kind of need an update of like where we are on our project and any needs for that. I've sent like some emails, but it's confusing when we talk about 2 different years. So
Gotcha.
what are
Okay.
we at?
Molly, I can take a, well, I'm about to say, I can take a look after this and I'll put that as a due out for us today to circle back on Greene County, make sure that you guys either have everything that you need submitted. I don't know if it's for the FY24 or FY or which grant year we're talking about, but
Yeah,
everything
I
should
think
be.
it was 23. Yeah, I think.
Yeah.
I
So
mean,
from what I understand, the 23, everything should be closed out for 23. But I will check and follow up with you after this
okay.
meeting.
All right. Thank you.
Thanks, Molly. All right, we'll move over to our health department. Beth?
Am I still muted?
You are unmuted now. You got it.
All right, great. Okay, so starting my grants, all of the FEP grants have been executed. I know a lot of you have already started completing your reimbursement requests. Somebody is approving them because I've seen the second month come through, so that's good. Your first quarterly reports can be completed now. Also in SIMP, the CPGs have been rolled over, so local health departments can start working on those. The CRI grants, as I understand, are at the director's office for signature. So once those get completed, signed, uploaded, then you should be able to start working on reimbursements for that grant. I just looked up the RSV and COVID and flu numbers for Illinois. In the last 6 weeks or so, we've seen a bit of an increase, but the numbers are still very low. So looking at emergency department visits, as of September 23rd, COVID is at 1.6%, flu 0.1, RSV 0.1, so the combined is 1.8%. CDC is concerned, depending on how these 3 diseases, how high they peak and when they peak, they've been running a lot of numbers, and if they all peak at the same time, there is going to be some backups at the hospital level. It will be approximately equivalent to what it was a couple of years ago. So nothing confirmed yet. They're just trying to plan ahead, and hopefully that's something that we won't see. And the last thing I wanted to mention was weathering the storm, and hopefully I won't steal anything from our Spark Coalition members. I just wanted to mention that that will be coming up in a couple of weeks. Registration is still open. I just checked, and I'll put the link in the chat, and I'm sure our Spark member will talk more about that. And that's all I had.
Awesome, Beth. So Marty, I'll pause quickly. Marty, if you would like to say anything additional about the Weather in the Storm conference or anything.
Thanks, Phil. No, I think Elizabeth hit it pretty well. Sparkcoalition.com. You can sign up. We're finalizing all the speakers, and we should have an agenda out shortly.
Awesome. We will be speaking, Lee and or I or some variant of the two of us will be speaking down there. So looking forward to it.
One other thing, Phil, I'm sorry. There are CEs available for nursing and I believe EMS as well.
Oh, wow. Very nice. So continuing education units available. Awesome, awesome, awesome. Appreciate it. All right. We'll move over to stars.
Good morning, everybody. Or I saw someone else come off mute. I don't know if Brad or did someone call in?
I think it's just you, Nick.
Okay. Real quick, I guess on the stars side, if I could speak for them, they have recently hired an executive director, finally. That position was vacant for going on about a year or maybe more. So Samantha Lewis is her name. So you may see her name around town. She just started back in September, I believe. So getting her feet wet and getting some projects underway there. I think they're also hoping to potentially fill a couple staff positions that have also been vacant for quite a while. On the Healthcare Coalition side of things, well, I guess back with stars, just for everyone's awareness, and hopefully you'll hear more about this as it becomes a little more concrete. St. Louis is hosting a dense urban terrain exercise that the Army puts on each year. It's been at several different metro areas the last several years. And next year in 2024, St. Louis will be the host. So I'm sure there will be some opportunities to partner with groups across the river. And I know we're hoping to make sure that the healthcare side of things has some sort of a role in that scenario. It'll probably be an earthquake with cascading impacts and things like that. So more to come, and we'll try to make sure you all are looped into some of that planning. And then probably the only other thing I'll mention from the coalition side is we also have a summit scheduled. It's our first time doing a healthcare coalition summit on the Missouri side. So that's scheduled for November 9th. And I will make sure that Phil and Lee, you guys get the invite and you can forward it along as you see fit. We're meeting, a couple of us are meeting today to finalize our speakers and make sure we've got everything ready to go. Then hopefully we'll get some registration information out about that. But again, planning for November 9th, unless unforeseen things cause that to change. I think that's about it, unless there's any questions for us.
Thank you. Any questions for Nick? Okay, hearing none, we'll move on. Appreciate it, Nick. All right, I got me saying this, but hopefully Mike was able to jump on. Mike, were you able to jump on to give some REMERT updates? All right, so before I talk, I'm going to toss it to Lee as being the next guy in charge for our REMERT team. Lee, you want to give some REMERT updates?
Yeah, good morning, everyone. So, the team itself has been relatively busy. We had the Belleville Marathon that we supported over the weekend. We've been trying to get some training and things lined out for the coming year. We were actually just tapped. I just got confirmation as this call started that we're going to be providing some first aid, search and rescue training for some of the Boy Scouts for one of their organizations first thing in the springtime, as well as some additional opportunities for decon, I think, are going to be coming up. We've had some additional requests, so we'll see how that plays. As far as anything significant, we don't really have anything major. We are still in a process of looking for some additional members. So if you have folks, specifically EMS, unfortunately, we run into some challenges with insurance for nursing staff currently. We really need to find a better way of accommodating the malpractice and liability for that. But from an EMS perspective, we can definitely cover that. If there's anyone who's interested, please reach out to Mike or I, and we can get you the application form and get you onboarded for that. Really, beyond that, I don't have anything specific.
Great. Thanks, Lee. Any questions for Lee? Okay, hearing none, we'll go ahead and move on. And now we're circling back from last month's meeting with our plans and governing documents and our vote, our annual vote that we kind of go through. So since then, we delayed our vote. Just as kind of a recap, from our September 6th meeting, we delayed the vote because there were some, we'll just call them technical issues with regard to visibility out in the shared folder and making sure everyone definitely had access and an opportunity to make comments and submit them into the comment review matrix. So folks went back out. With that, we did receive a few notes here, and I got those there, and we'll cover them here in a second. But we did have two kind of substantive recommendations received. One was from one of our Red Cross partners, Chris Hanna, who took a look at our TICP. I would put his ham handle in here as well, but I don't want him to get a bunch of random spam from folks. But was able to take a look there and identified that there were some tones that needed to be adjusted, and Lee took a look at that information and has made the correct adjustments. So this is great, when we have folks that do take kind of deep dive and take a look at things to help us find those errors. So that has been rectified. And Tina made a request to update our governing document to reflect attending 3 of 4 quarterly meetings from face-to-face to incorporate Microsoft Teams. I believe that's what I'm gonna pause and show you the exact areas where we're talking about. And Tina, I'll give you an opportunity to make sure that I understood what you put in the comment review matrix. But the top half here shows kind of the tones based on the repeater at Freeburg. Lee can decipher all of that and deciphered it pretty quickly and made the adjustments. So, and these are correct. So again, thanks a lot, Chris. In this section, in section 6 of the governing document, there says attend 3 of 4 quarterly face-to-face meetings. So as everybody recalls, we traditionally, and this has kind of been an oversight, I guess, over the last couple of years, we would get together, 4 times a year, twice at Anderson, twice here at Memorial Hospital. And when we held a kind of a survey on how we wanted to go forward with meetings, we were talking about, since COVID, do we want to try to get back face to face? So it was a mixed bag. It was a mixed bag of responses. So Tina, I'm gonna give you an opportunity to just expand on what you wanted to make sure, how do you wanted this to read, and we can kind of go from there. Do you mind providing a little more context to your comment in the comment review matrix?
It will be a little input, but since we're not doing face to face, and I think that seemed to be the consensus, not to do that for many reasons, and Microsoft Teams or Zoom or whatever, that type of format does work. So it was looking at this, we probably need to look at that and change that from all face to face meetings to whatever the organization coalition decides.
Gotcha. Okay. And quite frankly, I think we could probably just change it to a very neutral phrase to say attend 3 or 4 quarterly coalition meetings or whatever. That I think whether you attend virtually or in person is, you know, of not too much consequence with maintaining your membership. And I'm using air quotes when I say membership to the coalition. So does that sound right? You know, just basically make sure that we get folks attending 3 out of 4 of the quarterly meetings.
That's perfect, Phil.
By hook or crook, that's what I'll put in here. So unless anyone has any objections to that language. Okay, hearing no objections to that language, I'm going to just quickly review. Thanks, Johnny. I see you in the comments. Sounds good. I'll quickly review what we did go over last month. Again, these are the changes that were put through over the course of this past year. Again, so we'll start with the governance documents. That is the project proposal deadline moved from the 31st up to November 30th. So instead of December 31st, moved up to November 30th. That again helps us in ensuring that we get a grant that is we receive those grant funds in a timely manner. So the coalition annexes and support annexes basically maintain the continuity of operations, succession planning as written. The chemical annex, which we did our exercise and medical response surge exercise, our mercy exercise with, mimics the radiation annex. Again, does not provide treatment guidelines, unifies basically all the PPE that we've discussed over the years. So just as a reminder, if you're submitting project proposals for PPE that's not in line with what we've put in the plan, that's probably not going to be approved. Maintains an independent ChemPack annex instead of incorporating that in the ChemPack. And then the focus being going forward this year is to try to combine these into a CBRN, a chemical, biological, radiological, nuclear response surge annex for the coalition. Okay, so these are the changes in the governing documents. You can see that there, just got that highlighted. Again, the treatment protocols, again, that's we as a coalition are not going to tell you what to do at your organization. You have medical directors that are paid, you know, chief medical officers and chief nursing officers are paid lots of money to make those decisions. And we don't want to go against either your system or your independent organization. So none of our surge annexes will go into treatment. Again, just make sure that you develop your own treatment guidelines. That's what it says in your responsibilities for providers. Here's the PPE annex for first receivers. This is the recommended table I was referring to. Right. The ChemPack annex, again, it references that in the chemical response annex instead of trying to incorporate all that into one. And those are pretty much it. Unless someone had something that they had to have in there at this point in time, would someone like to make a motion to vote on these as written?
Phil, this is Tina, and I will make a motion.
Okay, great. And I'm going to take Scott because he put something in there in the chat that says he'll move for a vote. I'm going to take that as you're seconding it, Scott. And we will do a vote by, I guess, abstention. If you do not agree, you can raise your hand now or forever hold your peace. If we hear no disagreements, then we will pass these as is, and they will be posted, and we'll do this again in 365 days. I do see a hand raised. Trying to see who that is. I apologize. Eric, go ahead.
Yeah, right, Phil. I had a couple of typos that I had noted I had just never sent to you out of your red response annex. I'll send those. They were very small. One of them said not when I think it meant note, and another one was a misspelling of response. But in the EOP, as I reviewed that, there were a couple of them that I thought stood out. One of them referred to using Mid-America Airport during a NDMS activation, and I don't believe that is true anymore. Is that accurate? Because didn't we move that to St. Louis downtown?
Yeah, it's
Yes,
at downtown
Eric.
parks now.
Yeah.
Yes.
Okay, so that was one of the things I flagged, and I'll send you all of this crap that I'm blurbing out now. I have written down, but the other thing is, I also found in the EOP it made reference to the 2017 healthcare preparedness. I can't read my own writing. I
The
think I meant on.
capabilities. You're talking about the
Yeah.
capabilities. Yeah.
Has that
and
been
that's been
updated?
changed. Yeah,
Okay.
it's been changed.
So that was pretty much all I found. So not a huge deal, but I just want to let you know that I will send that out. Other than that, I'm completely okay with all these documents, and I'll shut up and we can vote.
Perfect. And yeah, that NDMS one, that's an overlook on my behalf. I forgot about that. So appreciate it. Do we see we got something in the chat? Whether when approved, where can we access it? Okay. So it will be in the very same similar box where you're able to access it now, except a folder up. So, and that link will be on it's on our Member Planet page, but given that, I will send it out because I know a lot of folks sometimes don't navigate that area or go to that specific site. So I will forward that link out again, so that way you have access to it, Tina. And thank you, Eric, for making those notes. So, any others reasons why we should not move forward? If not, the proverbial and virtual eyes seem to have it. And thank you. Well, again, as always, these are living documents. If tomorrow you see something is wrong, feel free. Tell us, let us know, and we'll fix it. And that makes it just easier the next year. Awesome. All right, moving on. Redundant communications exercise. Semi-annually, we have to conduct a redundant communications drill per the ASPR guidelines that accompany our grant. So within the scope of work, that's something that we do. You guys always participate, whether you know it's the exercise or not. But in this instance, we were basically testing out some of the contact information we have in Member Planet through sending Everbridge notifications through again our Everbridge service that we use for the coalition. So we sent those those communications via SMS text and phone messages to your identified work phones that were there. So out of that, we send it to 35 regional contacts, and that is a tailored cut 35 that IDPH requests that we align to. So when we submit our annual membership kind of makeup, there's a list that we pull together that meet all of the, whether it's emergency management agency folks, public health, hospitals, and EMS. We put that together. So they kind of judge it based on that. That's what they want us to target. Not everyone we have communications with. So that targeted 35, 32 folks received the notifications. There were 3 that were unreachable, and that was basically some data either missing in Everbridge or Member Planet. And we're communicating with those folks to make sure that they update those so we don't have that in the future. Of those, only 13, so it was a 2-part exercise. You first received the message, as you can see down there. I have it listed there. And you were supposed to respond back through email. So we're testing 2 forms of communication. We were able to communicate to you through phone, text, and then you were to respond via email. So we only had 13 respondents of that. But 32 folks received it. And 11 did not confirm it. So, when you get that text message, there's an opportunity, or the phone message, to say press 1 to confirm or reply via text. So good on at least reaching out, that we know that the information is making it there. We'll make the corrections of the data that we have to make sure that that information is making it through that medium. But really want folks to, when you receive these notifications, fully read through the text or listen to the entire message and make sure that we follow through, so we can make sure that all systems are working. In some instances, we have IT network outages and may not have access to email, and we'd like to know when those impacts do occur. So any questions with regard to this? Is pretty low hanging fruit, but it is something that we go through. Next one you'll probably see is March of next year. So questions, concerns? Hearing none, we'll get to our upcoming events, and still a long list of stuff going on. We do have a first receiver decon class that's going on tomorrow out of Fayette. Our executive committee strategic planning meeting is next week. At that, we'll be trying to look at what we called in the past our strategic plan. We're probably going to change the name of that to our integrated preparedness plan, to be in line with all of the emergency management language generally. Then we have another first receiver decon on the 12th, HVA workshop, which every one of you should have received an email this morning for that workshop. So you can click on that link there to register for that, to let us know that that you are coming. It is all virtual, so that you'll be in attendance. I should say no physical location. Our next coalition meeting is going to be on the 1st, and the theme there is going to be HVA and National Weather Service stuff. So we'll be working through some of our HVA information. We'll have the workshop the week prior, and then we'll present some of what we discussed there. The IAM conference in early November, and then the IPPW workshop going on November 15th. And let me just double check that to make sure that that date didn't change. Give me 1 second to make sure that that date is correct. No, so that date on the screen where it says November 15th, the IPPW workshop, that is not the correct date. The correct date is the 29th. So it'll be the week prior. It'll be November 29th, a week prior to our December 6th meeting, which we will discuss that information. So very similar to what we're doing for the HVA, or the Hazard Vulnerability Assessment or Analysis Workshop. So that date's the 29th. So make sure you put that on your calendars, because that's how we got it loaded and member plan it. The National Healthcare Coalition Preparedness Conference in late November, 28th through 30th. Our project submission deadlines, November 30th. So make sure we hit those, and you can hit that link to make your 2025, that should say 2025 project request. So don't shoot me, because those years are starting to blend together, but that's for the next grant cycle. And solar eclipse planning is still going on, but April 8th, get your sunglasses ready for that day. Right. Pause here.
As long
Open
as it's
floor.
not
Okay.
So I said as long as it's not snowing, but I have a question on
Yes.
the
Go ahead.
HVA and CPG modules. And I apologize if I am out of the loop on how you're doing the regional. I know you're having this workshop, and I know some people are doing the Kaiser Permanente. Are you requiring the hospitals to go in, the ones who aren't doing their own, requiring the hospitals to go in and do the HVA in SEMP?
So
And
that'll be
the same
part.
question for CPGs.
Yeah, I mean, that'll be the same thing, because the work plan or the scope of work for the grant doesn't require it to be in SIMP this year. And the issue that we end up having each year is, if we do incorporate anyone outside of a hospital, which we'd like to be able to, because we'd like our EMS partners and all that to be able to. So we're going to try to have to find a method to do that as well. I have reached out, as some of you may or may not know, BJC, we're working with the latest iteration of the risk tool. Some of you may be familiar with that, but it kind of puts together a full VA for you where you can have multiple types of, similar to what we used to do in SIMP, and it would aggregate all of that information from different agencies and agency types. So we may look to use that, but we haven't got permission to use it yet. It was in kind of beta. It may have gone live, but I just sent a note to the folks to see if we can have access to it to do that. But these are some of the things that we're going to be discussing in that workshop. If all things don't pan out, we'll do what we did in the previous years is we'll do a hodgepodge of SIMP and the Kaiser Permanente tool. But we're really trying to spark engagement from those who are outside of the hospital as well, because, and you guys don't have access to it. So if I were to look at Kim Lamprecht, she doesn't have access to SIMP to do it. And some of that probably is not going to be in line with what an EMS agency would do for an HVA. So more to come on that. So please be in attendance if you can for the HVA workshop.
And
Hey, Phil,
and
it's
as
Lee.
for the CPG,
Oh.
you're not using that either to. I just want to know whether, personally, I'm just trying to figure out whether I'm supposed to go and review these, like,
And review them in the end.
review on them. You know, if we're not doing them, we're not requiring, then I'm not going to worry about it. But if you are using that information to do the regional one, then I'll make sure I go in and get those reviewed. That
And
was
get them
really
approved.
the crux of my question.
Yeah, indeed. And I think that's where I think we really need to, while it will be a workshop because we're going to discuss several things, that's one of the things that we kind of need to decide then. I don't know if there's an easier way, and unless everyone can see it all at once, if that makes sense. You know, if they can see what is provided using both the HVA and CPG tool within SIMP, if we take a look at what risk is able to do, which does very similar to what SIMP does, and then what other alternatives do we have, because after that, then we'll need to be able to collect and consolidate the information. But I would like those hospitals and everybody to be able to see it and then be able to go back and say, all right, this is what we're going to use, because we got so much stuff at our fingertips now. But we gotta, to your point, we gotta kind of make a decision on what's that going to be. The previous years was a hodgepodge of SIMP and the Kaiser Permanente tool. And if we're going to do the SIMP portion, we need to do the CPG portion as well. I do see Lee put in the chat, and I know you're about to say something, Lee, about the Risk 2.0 toolkit. Did you want to say anything about that?
Yeah, so in response to your earlier statement, we did get confirmation back from the folks at HHS.
Oh, good.
And yeah, they're eager to have the coalition involved, but it, I believe, has also gone live. Because if you go to that link that I sent, you can actually register for a risk for the account now and be able to start that process for your independent HSOs.
Yeah, I saw that yesterday when I went to the site, and I was hesitant to say it was fully live because we didn't receive any other updates from it. So, but good. So, yes. So the link that's I'll put it in the minutes as well, but the link that's in the chat right now, if you go to it, you can kind of get an overview of what it looks like. And I believe there are a few YouTube videos and other like kind of quasi training videos that are out there. But so that's one of the things that we'll be discussing as well. So pretty decent tool. The previous version, I will tell you right now, the previous version was, for lack of a better term, painful to use for some folks. Definitely painful. This one, a little more user friendly. So, all right. Any other comments,
Phil,
questions?
John Nowak.
Yes. Go ahead, sir.
Hey, and that is available for EMS too, correct? You may have already said that. I may have not heard it.
I'm pretty sure it's like agency style agnostic, if that makes sense.
Copy.
doesn't care if you're EMS or if it's what do you call it? If you should be able to use it. And normally it's for public entities, and you guys would be considered such, even though you are a private corporation. All right. Any other things from around the region, around the floor? Any questions, concerns?
Hey, Phil, can you hear me?
I sure can.
Cool. So just want to just kind of, I think I may have said it earlier in one of our previous meetings, but I'll just, like to reiterate that we are going to be hosting an active threat exercise full scale here at the VA on the 8th of November. I know I've reached out to some of the Hope Coalition members for Moulage. I was just on the SMOC call, so I apologize for missing some of your meeting because I just found out from Michelle Tanton that Children's will also be running an active threat exercise at Children's as well, using similar style resources of Moulage, live role players and stuff like that. So just wanted to let everybody know that their exercise is in the morning from roughly 7:30 to 11:30. Ours is going to be in the afternoon from 1400 to the evening. So just wanted to kind of relay that out there because I know some of the Moulage artists that or I should say Moulage practitioners that we got trained might be finding themselves working simultaneously in the same day for two separate exercises. So that's all I got, Phil.
Indeed. Thanks, Eric. And which facility specifically are you guys gonna to do that at? Which specific facility?
Yeah, it'll be John Cochran. So it'll be at JC. And today, just to give you a heads up, there's an LEPC for the city of St. Louis at 1. I'll be attending that as well. So we can get the word out with our city stakeholders. So once there's more information, I will send you an email to kind of give you who's going to be participating and in what capacity.
Perfect. I see we got someone with their hand raised. Tyler, go ahead.
Yeah, just a short tail on that. That is a statewide, supposed to be a statewide drill through IHA on November 8th for the active threat. So every hospital in the state should be participating in that, whether you want to do full scale or just tabletop, but just let everyone know that will be statewide.
Awesome.
Hey, this is Patrick from St. Joe. Sorry to ask. I got two questions actually. Well, two things. First one, as far as the Moulage you're talking about, if you're needing more assistance, especially since you were saying you might have people running between the two areas, if you would like touch base with me, I might have some options available for you for assistance with that. You can get me through email. Also, my question again, the other one is about the recent redundant communication drill. So with our systems still coming back online in certain areas, we may have had some people that were missed or didn't get those calls. Would you be able to send me a list from any HSHS folks that either you were unreachable or didn't respond so that I can make sure that they did get it? If not, we can look in to make sure that that's something that's not missing on our part from when we started coming back up.
Will do.
Yes, sir.
Will do.
Yep.
Awesome. Okay. Well, at this point in time, we're going to pause there. If you do have any other questions, concerns, feel free to send them to Lee, myself, or at info@swillhope.org. That means we all get it at one time. We're going to move over into our themed event portion of this month. So we'll be covering our common operating picture D4H and some EMResource tips and tricks. So for those of you who want to hang on or need to hang on to this portion, feel free. I would encourage it for all those. If you have not received any training or access to some of these, maybe you have an account in D4H, but you haven't done some things in there. Lee will be going over some key areas where we use it. And then in EMResource, I'm going to cover a few of the key areas like we've kind of done before a couple times, but I'll cover a few key areas that each of the hospitals definitely needs to make sure that they're doing to, one, increase their individual readiness within the organization in your own independent organization, but also to make sure that we're hitting the marks with our updates, whether they're both daily or when we do send out a bed query and we need you guys to update numbers to make sure good folks in the field know where we're going to route folks most appropriately. So with that, we'll begin the transition. So I'm gonna tee this up for Lee and he's gonna take over. But D4H, what is it? Basically, D4H is our real-time incident management software. It's web-based, so there's no downloadable software required. All you got to do is have access to a Chromium style browser, whether that's Chrome, Edge, and Safari. Those are the three best. At least that's what the company recommends. There are iOS and Android app versions available. You can follow those links there by clicking on them or scanning them with your phone. It'll take you to the your relative app store there. We use it in the coalition as our primary common operating picture for incidents. So through COVID, we used it the entire time. It stayed open for 300 and some odd, or way more than 300, I guess 600 and some odd days. We do all of our resource requests through there. When you're looking in the emergency operations plan, it shows you that little diagram that mimics what's in the IDPH ESF8 annex. This is how we manage that process from the hospital to the resource hospital to the RHCC, or to your local health department and EMA. This is what we use. And then special event planning. So we do use it for a ton of special events, and a lot of times that's REMERT that's doing that. They'll have their operations managed that. So without further ado, I'm going to turn it over to Lee. And Lee, you can take it over and I can stop sharing this if you need to share your screen. So I'm going to stop sharing this now and he's going to take over.
All right. Good morning. So D4H, for those of you that have a login, when you first log in, your page may look something like this. You probably will not have all of these incidents down here at the bottom, which is basically what these are, is incident. They call them channels. But when you go into this, one moment while did you get him silenced, Phil? Thank you.
Yep.
All right. So when you first come into this, you'll see the list of whatever incidents you're currently assigned to or invited to. But for the purposes of the day, we're going to go straight to the regional response because this will be our normal daily operations board. So anything that's going on, whatever may be happening in the region, if it's something that's significant that's going to affect us, this is where we would go to track that incident. When you first open it up, it'll bring you to the dashboard. On the dashboard, it'll give you a highlight reel. So you've got a highlight of the log file, which is basically just your ICS 214 form. And I'll show you how you can intelligently populate this and you can make it go to who you want, almost like a chat tool. You'll have the map, which the map is useful in some instances. In other instances, it still has some areas that could be improved, and they're working through that as we speak. It'll show you the total count of personnel who are assigned to this particular incident or this particular channel. Right now, there's 73 individuals, 2 of which are online. And then you'll see there's resource requests. So during COVID, for those that recall the resource process, this is how we handled all of the resource requests that came through the RHCC. Whether you phoned it in or you actually sent it in, it came in to us and we entered it as a resource request, and I'll show you that process momentarily. This also has the ability to do this region stat reps, the status reports. So in the event that there's something that goes on, you can actually come in and give us the status of your facility, so that we know what's happening within the region as well as everyone else. It just gives us some transparency so that we can all see, this is what's cooking and what we need to do to respond. The My Checklists feature, we haven't fully integrated it or implemented it as of yet, but this would be, as an event occurs, a checklist that shows you what tasks you have open that are assigned to you based on your role. Then over here, you'll see that I have two on my resource requests. These are things that were assigned to me that I've completed, so they show in green. And then when we look over again, the all checklists is just everything that's open that's out there. And then for ambulance services, this is for NOAC and for the folks at MedStar and any of the other EMS services. They can come in here and actually tell us, what their status is and if they're operational or non-operational. So that gives you kind of the gist of the dashboard. When you look at the situation section, the situation is basically like an ICS 201. So for anyone familiar with the ICS forms, this just shows you what's happening. Because this is a daily operations, there's no situation summary. This is just a normal day, and we just track everything. If there's something significant that needs its own tracking, we'll open a separate incident specifically for it, which we've done numerous times now for both real world and pre-planned events. But also inside of the situation, it does give a flow of basically who's responsible for what. And you'll notice there are some areas that are, as you can see, it'll give you the option to have notifications. But you can see there are some slots that are empty. We need to go back through and repopulate those. As people change positions, sometimes it's hard for us to keep fully up on that. So we just need to get some of that repopulated. But down at the if this were, let's say, for example, we did this during Amazon, I took photos of the incident from the scene and uploaded them into this so that those who are in the command post back at the hospital or wherever can actually see some of what we're seeing on the ground. This just allows you to add images, or I could upload files like rosters or things of that nature. When we go to the roles section, this just shows basically what roles are out there and who's fulfilling those roles at any given time. You'll see there's a lot of different roles based on organizational type. So for, when we look at resource hospitals, these are the EMS coordinators that we have in there. Again, some of them may be lacking either because we don't know who it is or because we just haven't got them populated yet. Same thing, some of the health departments, we have a few vacancies we've got to populate. The forms section, in here we have pre-done form folder for ICS forms. So these are all of the traditional ICS forms in an electronic format. So you can go in and actually fill it out on here, and then you can print it just using the little hamburger button here to print it. You can send it to a PDF. You can take a picture of it to email. You can share it via email, things of that nature. We also have within that same area, when you go to add, there's a list of all of the other forms, and there's a whole variety of forms based on different, like the stuff we use for remerts in here, as well as the Hicks hospital specific forms and some other just useful forms or things that may, we can always add more. They're very easy to create. When we look at the map, this map is set pre-populated with addresses and locations for hospitals, both inside of the STARS UASI region, as well as within the coalition. I actually have a list of all the hospitals in the state, but it's not all geotagged correctly, so I have to address that to make it work right. But once it's in here, it'll allow us to go in and select what we want it to show. We can also show weather and things of that nature on this map. The logs section. This is the part where, whenever something occurs, we'll come in and notate, hey, this is what we have done. As you can see, Phil put, hey, that I did this little brief out. If you notice, though, there's a little person symbol and my name. In order to do that, it's kind of like Twitter or whatever they call themselves this week. You @ symbol, and then it'll give you a list of anyone who is assigned to this incident. Or you can simply just go to all, And when you go to all, that means it's going to send this message to everybody. It'll show up. They'll all get a note to say, hey, somebody posted something. But the idea here being that if you do need to loop someone in, like when we had the incidents with some of the hospitals during the storms, I looped into Gilbert, so he would get a ping on his to let him know to let EMS know. Things of that nature. It just kind of gives us a little bit of an easier track for that. I talked about these earlier. This is the resource request process. So if you are a hospital and you're submitting a resource request, you just click on hospitals, and when it opens up, you can click on add. It'll take you to this form. You'll put in what it is that you're requesting. Just basically, I need cuts or whatever the case may be. And then when you go into the order, you'll actually hit in the add row, put in, I need 10 cots, and I'm going to call it other. And you just put them in for whatever it is. Down below, it'll give you a requested reporting or delivery location. Now, that's not to say that we're going to deliver everything, but that's saying that if it can be delivered, you want it to go there. If for whatever reason you're asking for a specific item, as happened during COVID, folks would ask for a specific like ventilator circuit or something to that effect. You got to be very specific on what you're asking for. So the type would be, the model number or whatever. If we, for whatever reason, can't do it, if you have some alternative that you can use in its place, let me know that as well. Because when Phil and I escalate this up, it kind of becomes useful for us to see, hey, do we have this or not? What your recommendation is, what the priority is. When we look at the priority, you've got basically three options. It's either I need it right now, I need it in a day or two, or it's low, get it to me when you can. The date time entered, when you click on it, it will automatically populate that. And then we ask that you put your name and what your position or role is, as well as your contact phone and email address, because it may not necessarily be the same person who's requesting as the one who filled out the form. So it may be someone else inside of your organization that we would have to speak to get specifics. If there's special instructions, that could be something that you enter or something that we enter as we're processing this. When it goes to the logistics staff assigned, we'll fill that in at this end, and it'll go to one of us here to make sure it gets done. And then it goes from there on, it's how do we source this? Did we have to pull this from our stock? Did we pull this from a vendor? Did we have to escalate it to your health department or to the state, or what happened with it? And then it just gives us notes. And then we will print this. If you're picked, for those that came and got stuff, we printed this and had y'all sign it. And then we actually scan it and upload it back in so that we had a paper and digital copy of the resource requests. So that is effectively the resource request process. What'll happen when we get it, you'll see it'll pop up like what you see here. It just shows me that there's been requests that are filed. And then I will just go in and I'll move it to either in progress as I'm waiting for an item. When I know it's done or you've picked it up or it's been delivered, then it goes to complete and it'll show in the green and it'll show that there's one less than there was before. For the checklists, like I alluded to earlier, we have not yet really implemented this. That is something that we're looking at. These are really ideally done on a specific specific type of incident. So each one would have its own checklist based on what you're doing. And we have not done that, especially for daily operations yet. When we talk about the stat rep, so to add a stat rep, you would click on add and you would just put in your organization. So I'm just going to say Memorial Shiloh. Yep, it's urgent. Need it now. You notice the color changed to red. That flags to us and lets us know that we need it. Remarks would be just that. Fill it in. Give me, when I say me, you're giving everybody, because anyone can see that, hey, you have a problem and you need help. Tell them what the problem is. Phone numbers for whoever the contacts are. For us, we have what we call red phones internally, which are our plain old phones that go around our VoIP in case our computer system goes down. We have a phone that still works. If you have some alternative phone that is not on your network, this would be the place to place that. When you go to your operational statuses, it's going to ask you, are you having no issues, minor or major? Injuries is basically yay or nay. Fatalities are yay or nay, and on and on. It just very general, basic questions. This is like the short form. If you do have injuries, we use this a lot internally for our internal stat reps. You can specify whether it's staff, volunteers, other, and you would just basically put in the number of injuries. That's kind of the gist of that. Your general census, how many patients or staff need assistance, no assistance, or maximum assistance. The staff census, you can actually go in and say, I've got, 4 MDs and 20 nurses on staff. That's what's available right now. That's what we have in-house. This is what we can, or, how many we can get within 2 hours. And same thing across the different categories that are assigned here. When we look at your utility issues, this gives you the ability to say, is it working? Yes or no. It's either operational or non for all of these capabilities. If you have something beyond what's listed in these 9, you can notate that here. Or if there's additional information relating to these, can only make internal calls or can only make external calls or whatever, you can document that there. If there's an immediate equipment need, got to have it now, put it in here. And this basically just allows you to notate what it is and how much of it. And it's not a resource request, a crisis intervention, if you will. We would still try to get a resource request from you for tracking purposes if we're sending things to you, just so that we can actually follow up should there ever be a need. Operational status, though, when we talk about your operational status, are you going to be able to remain up and running for the next 8 hours? Yes or no. If it's an immediate evacuation, then, obviously no. If not, then yes. And then any department or unit needs. So this would be for your facility. Again, if you have specific safety concerns or delayed needs, hey, we know that, water's out and we're going to need some assistance because it's not expected to be back up for 4 or 5 days. This is what we're going to need. And you can put that into the delayed needs, and that can be helped and used in the planning process. For our ambulance services, I'll use MedStar because John's on. Go ahead.
Hey, are you hitting a save or a submit button, or does it automatically save? I haven't.
It is all real time. It saves automatically.
Okay, thanks.
No problem. I'll pick on John because he's on the line. So when we look at the ambulance services, if they go to MedStar and he clicks on it, he can actually come into here and say that they're operational or non-operational. He can actually try to get it to pop up here. And there we go. If I hit the edit button, I can come in to put how many total units, so what he has available, and any notes. This is what he's sending, this is what he's keeping for 911 if there's an incident or whatever the case may be. That kind of thing can be notated. And Phil, we might want to make sure that's in here too. But that just gives us some transparency on EMS. These are just the services that are within the SWIL EMS system that we've got in here, or were in SWIL. Some of these may not be now, but that's what we built in initially. But you can go in and tweak and edit and change and make it work for your HSO or for your ambulance service in this instance. The personnel side allows you to see all the personnel who are currently invited to this incident and what role they may have. We can edit roles as needed so that they are, in a role that they belong to. So for example, with, where's that? With John Nowak here, I'll click on it and take him to MedStar. And now when I go to personnel, John is now showing as Hope EMS Services MedStar Ambulance. This tells us what organization or agency you belong to. Here's the catch to this. What I'll say is for Gateway, where they have multiple folks that we work with routinely, there's not really a way to do this so that it has everybody tied to one thing. We would have to add like a number or something with this. Unfortunately, we cannot have multiple people assigned to one role. A role is an individual position. So until we can come up with a better solution, there'll be one primary and then anybody else will just show unassigned until we can find a solution for that. But this gives you an idea on what the personnel looks like. If you need to be added to this, if for whatever reason someone does not have access to this, please let us know. Send a message to Phil or I, or to the RHCC at swillhope.org, and we will ensure that you get added. If you have members of your team that need to be added, please, we need that information. First name, last name, email address, and ideally what their position is so that we can add them. But again, this will show, if it's a green dot, shows you that they are presently logged into the system. They are online now. The weather option, this just gives you a forecast. Basically, this is a service that's provided through the tool that they have, tomorrow.io, and you can come in here and take a look at the next few days by hour, what the expected conditions are going to be. For notifications, this is something that we can use internally to send messages out via our Everbridge to the coalition as needed. And then in the library, we have our HCC plans and annexes. So this is all of the files that we put in the box. We keep a copy in here. Once all of the plans have been approved and everything is ready to move to this next current version, we'll replace what's here with the newly updated. The map annotations just shows you all the things that we have basically bullets for in the system. For some reason, they chose to title it that and stick it here. We don't really ever use it, but it's there. One thing I will say is on the log, you may see like this here where it says the conditions. If we have an incident cook off, like right now, I can go into this and I should be able to they moved it on me. I should be able to add the weather to this. There's usually a button here, but for some reason I'm not seeing it today. Peculiar. Okay. But anyway, there is a way to have this auto-populate so that it captures that weather condition at that time and drops it in. And it's kind of centered in the middle of the coalition so that it's just kind of pulling for the whole entire region. We can't easily have it pull for every individual place with the way we're set currently. So with that, Phil, do you have any specific things? Did I miss anything?
I won't say you didn't miss anything. I will say that if you would go back to the checklist, we'll give an example of what that kind of looks like. Go back checklist and then go to the hamburger. Nope, just go hit cancel. Yeah, and import and go to Kimpack. Go just type it in the search. It's probably easiest. Yep, the second one. Yep, just go ahead and import those. So what you're seeing now is if you look in our Kimpack annex, in the back there is a kind of regional response checklist to that, and as this loads up, there you go. So there's 189 different steps, and this is the full stepwise checklist of what we were to do if and when an incident potentially kicked off. This is one for one what's inside of the Kimpack annex right now. So this goes through every portion from the identification to notification and to who it's assigned to. So this is one of the reasons why we hadn't assigned everything yet, because some things we had to put some general points of contact or placeholders for. But if you just scroll down through this whole thing, it kind of goes through everything there. And as you can see, it's pretty long. So if you just want, go ahead and I guess we can go in there as go back to your dashboard, Lee. Once you see on the dashboard, you'll see that this checklist is available and it's going through. And as I start to go through each one of these, you'll notice that there are things, if the in progress meter continues to go further and further and further. So this is what could help, but would help keep us on track of what we've done, what we haven't done, and give everybody visibility on it. Again, the reason why we have a common operating picture. There is also something within, I guess, the entire portion that's unique to D4H that you may not see in other areas. So two things I'll show you is if you go into, you can go into pretty much any area. Let's start with the ambulance services. If you go back to the ambulance services piece, and this is called a status board, so that's why it changes colors. If you were to double click on Abbott EMS and go into their status board, in the top right, right beside the hamburger, you'll see that message area. Go ahead and click on that. Now this, right now, we're selected into the ambulance, the Abbott EMS admin service. If Leslie was there and wanted to talk about certain things of what's going on, you can talk right here, accessible to everyone. So if Lee were to make a note, so if you were to make a note in here, yep, he would put that in there, and okay, you go ahead and enter. Everyone will get a notification about it, and it'll be tagged to this one piece. So this has its own individual conversation that's kind of going on. If he goes back to the log, you'll notice that, boom, there is something on this. And then it has a little link where you see the little ambulance area, Abbott EMS. So everyone is made abreast of what's going on. If they wanted to go more specific into that, they can go back to it, and it will continue that conversation here. So you can kind of have things containerized there. Same thing can be said for if you'll go to the library. I don't know if you talk about the library much, but it's a basic library. So yep. So if we were to see this here, right, that's the Kimpact checklist, the checklist that we were talking about earlier. You have that available to you, but you also, again, have the exact same thing. So if you click you'll notice that there aren't any conversations about this document. So you could put information here. This could be a great place where you said, hey, I've got, I noticed that there was an error here. I noticed there was an error on the checklist, and you can at Lee or myself, hey, and we'll get that. And even if we're not in D4H, we'll still get it via email. It'll send us an email that says, hey, I was looking at the Kimpact checklist, and I noticed that you did not have X, Y, or Z noted. And we can be like, oh, great, thanks. And we can continue to track that until it's closed. So I think that's pretty much it that I would kind of recommend, or to say if there's anything that you need to kind of know. It's very user friendly. We can't really break it. Some of your permissions kind of won't allow you to break it in most instances. It'll allow you to input information, but it won't allow you to kind of delete something away from us. So the information's here. It's for us to use and for us to kind of keep everybody engaged, especially when there's something going on. So Lee just jumped in, as you can see. Again, this is a different channel, but as you can see, he jumped into the Belleville Marathon piece. And if he was on, well, while he's in there, I'm in a completely different channel, and I'm just going to send him a message, even though he's in a different channel. You see, he just got a note that said you have a message in there. He can click to it. It takes him right to it. So super convenient, very easy to use, and keeps everybody on the same page. So,
and you'll notice.
Go ahead.
You'll notice, depending on the type of incident, and my browser is bogging down. Bear with me here for a second. This, unfortunately, is not a problem with D4H. This is my IT department. It'll come up in a second. But you'll notice if you look at the left column, depending upon the type of incident you're in, you may see different options on that left menu because there'll be different features that are available based on what it is you're doing. There it goes. So over here, you'll see the same resource request and checklist, but you'll also see things like media statements, medical call tracker, triage. These are things that we have added so that, when we're talking a medical call tracker during events, whether it's, marathon or the air show or a community event, you can actually, if you don't have dispatchers sitting there with full CAD capability, like what, MedStar typically shows up with, this could be something that's used in lieu of that. Whoever's answering the call, taking the phone call or the radio call from the dispatcher at the 911 center, can go in here and put a description. Hey, I've got whatever the case may be, report of a, man down. Yeah, it's in the 4 or 3 East parking lot. You can go in and select what unit or crew, in this case, because it's how we had it built, you were sending. What is it? It's an unknown. Give them some notes. Tell them what the status is. Okay, cool. They're assigned. When they get on scene and they call back and say, hey, we're here. Cool, we're tracking it. We know we got to watch this one because it's red. It means that unit is there. We're waiting for an update. And then when they say they're complete, boom, it's green, it's done. What was the disposition? Hey, in our case, we took them to either the field hospital, the big hospital, or they signed a refusal and we said, see you later. And then it allows us to track that down the pike. This is just another option in lieu of whether it's EMTrack or CAD software. This just gives another means by which we can track things contingently if needed. For the media side of things, like COVID being a great example, you're getting requests. Well, what is it that people want to do? Your PIO can come in here and actually put the headline. If they double click on it, it'll open to a full form and they could put in the full text of what their press release would be. And this would be visible by whoever's the incident command, and they would be able to come in and approve or disapprove. Say, hey, no, you need to change this. This is, too wordy or not wordy enough. But that gives that the triage, again, it goes back to when we add it, this is the reference number would be the bracelet number or whatever's on the triage tag, what time it is, what are they? Red, yellow, green, black. If you double click on one of these, again, it goes to a full form. The full form in this instance doesn't have any extra information. This is just a very basic form. But these are all things that we can create on the fly from the administrative side. And like I said, I apologize, my network's having issues with but again, every incident has slightly different feature set assigned to it, and they're highly customizable.
Indeed, and we build all that out, and if there's something that we need specific, we just ask the vendor, and they work with us with a lot of things. So we'll pause here, and if you got any specific questions or capabilities about this, just let us know. We'll pause for a second.
I'll also point out, if you see, sorry, John, just one second. If you see what I'm doing here, I'm actually shutting down a channel. When I shut it down, it does give us the options to export it as an activity report, create a downloadable archive where it'll produce all of these in PDF files so that we can go back through all of the things that were built into the system and actually view it. It'll appear in the archive down here. And once it's downloaded and it's done, it'll actually notify you that it's completed and you can go in and view everything that's there.
Indeed.
Go ahead,
So
John. Sorry.
Go ahead. Yeah, John, you had a question. Go ahead.
Not a question. How do I? I like, again, when we're doing these large events, man, I like that medical call and I like that triage. Is that something that you would have to assign to like each incidentally, or is that something that if I click on the MedStar or the ambulance that I could get to that?
No, so that is only in certain channels. It's not like in the daily operations because we wouldn't use that for daily ops. That would be more like if we were like we do an EM track where we open an incident, that would be
Yes.
just that. So I would come in here and click start new. And then I would select, these are the different kinds of incidents that we have built so far or are in the process of building. Some of these aren't fully vetted out yet, but I would come in here and choose what it is. So like
you could do this on the fly for me. Like at our big fire where I had, out in Madison, where you could create that incident for me really quick and then add that so I could keep a medical record or even like a rehab record.
So I just opened up a first responder rehab. And I can come in here and, okay, so I don't see, I see the ambulance services. I don't see the call tracker. I can go and I can add the call tracker.
Bottom left.
I keep wanting to go to the admin side. There it is. I can add it. Now it is there. And now you would be able to go in and populate it.
Wow, I like that. You're going to get more phone calls.
That's fine. Any of us can activate it from our phone. So no problem.
Any other questions about D4H, its use cases? We are looking, I will tell you now, we are looking at, for those who've been here a while, when we first started with D4H, we started with the personnel and training portion. Now they're beginning to blend both of these together, the incident management side and then the personnel training portion. The goal, well, I won't say the goal, but what we've asked them to look at is providing us a child or parent-child kind of umbrella account to where we can have a regional account as well as have a give individual accounts beneath it for hospitals and EMS. So you could run your own version of it beneath ours. Now, us at the region level would be able to see, but agency to agency wouldn't be able to like dig into your individual information, only accept the region. So that's something that we're looking at as we continue to use this. We think it's a great tool. We use it when we can. It helps us keep track of lots of stuff. So we'll pause here on D4H. If you do have any questions, feel free to shoot them to Lee or myself, and we'll transition over to EMResource so we can cover a few things. Just double checking the chat to see. All right, Kim, she asked, does she have access to this? We'll double check, Kim, to make sure that you should have an account. I believe you do, but we'll have to double check.
All right, and then like I might have to reset my password because I don't remember it if I have
no
an
problem.
account.
No problem. No problem.
Okay, thank you.
Uh-huh. All right, I'm gonna go ahead and share my screen as my mom was just calling me on my cell phone, so I don't know if you heard those buzzes. I had to send her the voicemail. I'm gonna blame it on Lee. So, all right, we're all right. So here in EMResource, few things that we want to cover to make sure that we are, one, updating appropriately, but two, want to make sure that you're able to get the information that you need and the notifications that you need. Patrick, do you see a hand up? Did you have a question?
No, I think that was actually probably just a delayed reaction from earlier when I talked. I apologize.
Not a problem. Not a problem. All right, so we'll start here. This is the initial dashboard in EMResource, and I guess best thing to do is probably clarify the information that everyone is seeing when they go in here. As it says daily hospital resource availability tracking. So everything that you see here in our region, so you'll see it says region 4, and then below you'll see region 3. Why do you see region 3 and region 4? Because we do have two hospitals that are in EMS Region 3, Carlinville and Jersey. they're in our public health and emergency response region, the Edwardsville region. Don't ask me who created it, but our good folks in Jersey and Carlinville are part of our region. They're part of our coalition, but their EMS region falls within EMS Region 3. Okay. Again, you are seeing availability numbers. So when these are updated, as the old have bed query used to take place every day prior to 10 o'clock, and we here in the Edwardsville region have agreed to update between 0600 and 0800 every day when we do our updates. They are putting in what available staffed beds that they have available at the time when they're doing this. So I know if your hospital is anything like ours, you got a bed meeting sometime in the morning with the house soup, maybe your CNO, and or your nursing directors. They get around, huddle, and they decide these numbers and then they update it. We used to have a very convoluted process. Now it's our house supervisors and house supervisor secretaries that are updating this information. And and for us here at Memorial, our numbers, the way we're updating our percentages that you see on Dan Lee's report have gone up dramatically over the last 8 to 10 months. Now that we're doing that as our process. So again, first thing you'll see is ED statuses, whether they're open or they have something going on. ICU, med-surg, burn, PICU, peds, psych. These are all bed types. Your ORs, your ED, NICUs, other staff beds that you may have, your blood supply, your decon throughput. This is how many folks you can get through per hour. And if you are an NDMS hospital. So just a general overview of what you have here. As you see, when I clicked on that green banner at the top, it took me to a similar page, but now it basically gives me all the totals, the summary of all of that information, and I can read individual comments that may be put into EMResource. If they're too long, you do have to hover and you can kind of see it. So I'm looking at HSHS, is that St. E's? Yep, St. E's says large D content available. So this is their comment for their decon area. If I were to go into a specific one, so I'll go into ours here at Memorial Hospital Belleville. I'll click on that and I can see all the basic contact information that you have here. It's got my desk phone here. Look at that. It's got Lee's phone. Look at that. Who you need to email. These are the house supervisors, phone numbers, and then going through, you'll see the individual availabilities and statuses. Starting with the ED status, as you see, we're open. If you click on that and you want to change it, these are the options that you have. Please read them. I just always recommend that you read them. Anything that you change if you have to change anything in here, make sure you're putting a comment in here. If you are on if you're open, but you have, let's say your CT is down, this is where you want to put in that information, and hopefully you've already communicated that to your resource hospital and to the EMS providers that you do have. But your hospital will remain, your ED remains open. You're not on bypass. You put in here CT down, estimated repair time 5 hours. Estimated time of completion. You can put ETC or ETA so people understand it. You can put 1,600 hours. That gives good enough information. Greg will see that. I'll see that, etc. So that's how you would communicate that type of information. I'm going to hit cancel because I'm not going to adjust that here. But this is where you can see all the information and you are going to update it. So the 3 areas in which you have here are the availability, what staffed beds you have open. So when you look at that information, if I go on here on my med-surg and I look at that definition, it will tell you the number of medical surgical care beds that are not currently in use, which a hospital attests to being able to staff for patient use within 4 hours for patients admitted for 23 hours or longer. So somebody you're going to bring in an inpatient setting. Then you get over here to your capacities. These are basically the maximum that you can kind of do. This should probably be the closest you can to your census, if not, or excuse me, to your licensed beds. And then these numbers here in the surge capacity are where you can balloon up to above and beyond. Okay. Now, when updating daily, my recommendation is that you start from the dashboard area instead. Let's go back. All right. You start from this area and you'll see these keys, this good old set of keys here. You want to click on those keys. Now, when you click on the keys, it brings up, what does it show you first? These are all of your basics and your daily availability information. What I recommend you do is you click show all statuses. Okay.
Hang on, Phil.
Go
Go
ahead.
back for a second. Can you go back for a second?
Go back here.
Hit the key again. Yeah.
Okay. Yep.
Okay. Click on select all. Never click on show all statuses. There, they all pop up with their easy way to change your numbers and update your numbers.
Indeed, but you don't want the other information updated?
Well, if you had to, but capacity is rarely updated. Capacity almost always stays the same. This brings up the five or six bed changes and 3 or 4 resource changes that you need for the daily bed reporting.
Okay. Key thing is that what you'll want to make sure you're doing is making sure you're hitting select all. So here I'll clear them all and then let you see it again.
And I don't mean to, that's what clearly is stated in the instructions, that you hit select all.
So they're not requesting that just so we're clear, they're not requesting, there's no requirement to update your 24-hour surge capacity information anymore.
Not on a daily basis, no, only when it changes. So your surge capacity is going to probably be the same all year long, unless something major happens. Your bed capacity, if you have 20 ED beds, you have 20 ED beds every single day. But you only have X amount are open. So those are the only things that you're updating on a daily basis. Now, if you close half of your ED because you're doing construction, well, then you would have to go in and change the capacity of your ED bed.
Okay.
Does that make sense?
Ensure. Yeah, makes sense to me. Fine. The second piece, you again want to make sure one of the other ads that we've got, where'd it go? Your borders. Big key on borders that this one should be updated. I don't want to say in real time, but as you experience high borders, you may have updated this today. So let's say you have your daily update. As you can see, these were updated this morning after bed meeting. But at 11 o'clock, your ED is slammed. You didn't have any borders at this point, but at 11 o'clock, you don't have to go through the whole update, show all statuses. At any point, you can always click directly on the number and it'll bring it up. And you can adjust it and then save that, and it will only save that specific one, and that time will change. To make sure that you're qualified for that day, you have to do it. These dates have to be on the day of and prior to 10 o'clock. Now, if you missed the 10 o'clock time frame, please make sure that you still update it, just to get your information updated so you're not counted as tardy and the information is just present for everyone. When we sent,
just so that's clear, this is what the issue is, that not going through the key, not going through the select all. And we know that's frustrating, but it is the only way you're going to get a check mark that you did it that day. So you want to make sure that when you do your 10 o'clock update, you don't do it the way Phil just did it for the ED borders, because you will not get credit for it. Once you've done it that day, then you can do it the way Phil if you're just updating for that day. But when you do your daily and you change your med surg and you change your ED numbers, it has to be through that key for you to get it. And that is what's not happening. Lots of people are going in the way Phil just did and go, oh, only our med surg and our ED beds changed. And they go in and they click on those individual ones and change it. That will not give you the credit that you updated the beds. Only through the key will it give you the credit that you updated the beds, which you must do once in a 24-hour period by 10 o'clock.
go ahead, Tina.
Bill, can you go back to the region list of hospitals and click on, for instance, would you click on Fayette County in the blue? Yes. So when you look at that, you know, Phil, we had talked about the ED status, and when I did it yesterday and I said the CT was down and I went in like you had talked about, putting that in the box, and I saved it. I know today you put the example in and canceled it. When I went in yesterday, I could not take that out of there. It wouldn't go out. So I contacted Jabari, and what they told me, because I put it in there, that's permanent and there's no way that I can remove it.
They said that the part that you put CT back up is permanent. Is the comment that you have in there now is permanent, that you can't remove it? Is that what you saying? That's what they said?
That's what then when I talked to them on the phone, then they emailed me because I said, how do I get that out? Because we're up, I don't want it in there anymore. And they told me it was permanent and it can't be removed.
Well, I just removed it. There you go. So you just have to resave it blank. Just
All
like
right.
I did.
Well, maybe
So
you
when you
should
go
be on that team.
Yeah, I don't know why
And I just got a notification on my phone that Fayette just updated their status.
Yeah.
So it worked.
Yeah. And this is the second part that we're going to talk about here over the last 10 minutes or so. But yes, just re-update it. Yeah, it will stay open to open because you stayed open. Your CT was down and it went back up. All you got to do is when it comes open this time and there's nothing in here, just hit save again and it will just overwrite it with a blank. Whatever's here at that point in time, it automatically overwrites it. So, so yes, the ED status should be a live entity every day. ED borders should be live entity every day. Okay. After you've made your daily update, live entity, make sure that, you know, we're keeping folks in the know of what's going on. Now, the second part of this is that this is for all intents and purposes, another common operating picture. It's keeping all the hospitals and folks who have access to this information on the same sheet of music. It's got chat functions, it's got a few other things that we're not going to get involved with today, but you as an end user need to know how to get the information and when to get the information. As you heard, Greg said, hey, I received the notification that Fayette has changed their ED status. It does not, EMResource, when you get an account, But when someone sets up your account, it does not come pre-populated with the notifications and thresholds that you want to have sent to your phone or email. It just does not come that way set. You have to go in and set those preferences for yourself. So how do you do that? Here in the preferences, there's two areas: notification preferences and status change preference. What Greg just got was a status change notification there. So I just clicked on, under preferences, I clicked on notification preferences. And here it's got all of the things that I want to receive notifications on. So all the system notifications, ICS notifications, I want it via text and email, and I can set these to my heart's desire. So when I get down here for high priority announcement, so there are 4 things that we have written in the plan that each hospital is supposed to have set up. There's a high priority announcement, there's MCI alert, there is, where's the other one? Am I passing it? Did I miss one of them? Maybe I don't have it on here. It's high priority announcement, MCI alert, and I thought I had them on notched on here. Is it system notifications? I have to pull it up. So give me a second on that. There are 4 we're supposed to have. I'm pretty sure I got all 4. Maybe I'm missing one. Oh, it should be a public health announcement. I don't know why that one is unchecked. Mobile app. So I get those at all 4 page spots. Let me save that. And then there's one more, and it makes you double check your preferences when you go back. So let me go back to notification preferences. This is where you want to make sure that you're updating them in how you want to receive them. Go back, and then I'm going to go to, I guess I could have went there, status change preferences. Here in the status change preference area, right now, as you can see right here at Carlinville Area Hospital, I got this for Region 3. I have an ED status type. When they go on bypass alert update, no ED, I got it. This is when it's going to send me something when that happens at Carlinville Area Hospital. So each one of the hospitals I have, when your ED status changes, I want to know what's going on. All you have to do when you get here, it's probably going to look pretty blank. You'll go through the add process, and then you got to kind of, I hate that this doesn't just pull up everything that you have, but let's, there we go. So as I just put in this category and just hit enter, it pulled up everything that's in the entire catalog. Now I can squiggle that down by changing, make that go down to everything that's in our region. And now I have what I want here. And I can select all of those or select each individual one. And then as I do that, I can switch those. So I'm going to put it Anderson. If I hit notification, I go through here in statuses. And then as you can see, no ED. So under the ED status, I have no ED. I want it via email, text, mobile app, and web page, bypass alert. And right now, as you can see, I don't have this one as open. So I would not get, and I changed this one today, I would not get the open status change from Anderson Hospital. So what we did today with Tina over at Fayette, I would not know when they went on CT diversion had I not checked this open, I call it CT diversion, but know that the CT is down. I would not know that unless I had this level checked, or I was just monitoring EMResource. Now, I could have the dashboard up all day on one of my screens here, and as things change, I could see it and go, oh, okay, what's going on over at Anderson? Because I would see a note if I was looking at it specifically, but I wouldn't get anything on my phone, webpage, or anything else. This helps me. So at 6 p.m. when I'm at the house, now I know that I'll get all of Anderson's ED status changes. So those are I think, 3 key things you want to make sure you know. How to update your dailies, as we discussed, and where to set your notification preferences and your status change preferences. This is what's going to keep you informed. Every time we send out a MCI alert, whether it's an exercise or it's a real world, I think folks do a great job at, we do a fairly good job. I think we get about an 80% response rate, especially for the real ones where folks are updating the red, yellows, and greens. The one thing they fail to do after that, because I always put that in the note, or Lee puts it in the note as well, is to update your bed status as well. Yes, we want to know what your ED can handle, but it may be an incident that may cause an evacuation of somewhere, or it may be like a nursing home or something. We still want to know what beds you have available. So the very first part where we started at, this needs to be updated right after that. So you get an MCI alert, you put your red, yellows, and greens, which your ED can handle, then you have to immediately update your availabilities for beds, ventilators, all of that information. How many med surge, We need to know that information that night at the same time. So it's not just red, yellows, and greens for the MCI. So I'll pause here and take some time for questions. We got a little bit of time left. Questions, concerns, things you need to see inside EMResource.
Hey, Phil.
Yes.
I was just going to add one other thing. If you want to get texts, because texts are great, and for those people who are concerned about timing, you are able to say from what time to what time you want to receive texts. So let's say you're the daytime person who updates the bed numbers. They may not want to get an MCI update your bed between 11 p.m. and 7. So you'd have your night nurse or your night manager would set hers up that she would receive those during that time and not receive them from 7 a.m. to 3 p.m. because that's when she sleeps. So that's an option in there as well, just so everybody knows.
Yep, I just pulled. Thank you. That's a great point, Greg. I just pulled that up. All you got to do is the user will go into their account information. So I'll do that again. Go to my profile. I'm already in my profile. It'll send you here. You can scroll down right here to your notification preferences, and you want to select that excluding during time range if that's your specific scenario. Because some folks may not take call or not have call, but they want to get stuff outside of a specific time frame. Okay. Questions? Any other questions? I'm looking in the chat. Okay. I see Lee's answering some questions. Okay. All right. Well, I'm going to stop sharing this. And we'll kind of wrap it up here. I thank everybody for jumping on here, listening in. This again will be uploaded to YouTube here in an hour or so, maybe 2 hours this afternoon. This is something you can fall back on and refresh yourself on, like, oh, where am I supposed to go? Where do I get this? This will always be out there until YouTube kind of goes away or EMResource changes as it has over the past couple years, some slight changes to it. So if you got any additional questions, again, you can send them to either Lee or myself. And always you can send them to info@sewellhope.org, and we'll all get the questions or concerns. Thanks again for everyone, and we're going to end it out here. Take care.